Hel- Hello, everyone, and welcome to today's Journal Club discussion on association between the history of cannabis use and outcomes after total hip or knee arthroplasty. It's a systematic review and meta-analysis. Next slide. Joining me, nope, the previous one. Introductions, there we go. Joining us today are three esteemed doctors and researchers. Dr. Phil Malloy is a rheumatologist and continues to be very active in caring for patients despite retiring. Dr. Jehan Marcoux is a cannabinoid researcher who's worked in the cannabis area for over 20 years and has recently published a book entitled Regulated Cannabis and Hemp Market Navigation. I believe you can order it through Barnes& and Noble. If you have any questions, you can just send that to us in the chat. And Dr. Len Kamen, hopefully he joins us. He's from Jefferson University, the clinical director of the Moss Rehab Outpatient Center and the president the president of the Rothman Opioid Foundation, and he's a member of the Pennsylvania Pain Society. Next slide. For those of you new to our program, I'm the CEO of Physicians Research Center Plus, and we have three areas of expertise: SALIS, which is our clinical research, phase 2 through 4 clinical trial program. Buds Info is our data and analytics area, and then Cerium, which is our education pillar, and that's, what's sponsoring the journal clubs. It's designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. Next slide. For those of you who are new today, it would be greatly appreciated if you scan this QR code. It's just a questionnaire about both a little bit of knowledge, a little bit of attitudes, a little bit of what we could do to improve our program. So please take a minute to scan it, and it shouldn't take you too long. And I'm going to thank you in advance. Next slide. All right, so now I'm going to hand it over to Jehan Marcoux, who's going to kick off the journal club.
All right, hello and welcome everyone. Just to get things started, the mission of this journal club and why we meet is to support the education of healthcare professionals with discussions of published research. And we do our best to approach each paper we discuss with consistency, fairness, and transparency. If you would like to receive correspondences and invites to more of these events, please share your email in the chat. And again, the purpose of this journal club is to educate and raise awareness. We're not making any policy or regulatory decisions here. So first up, hot off the presses, we discussed these synthetic isomers, artificially derived compounds, neo-po-derived man-made compounds have made international headlines. So Phil, Dr. Malloy, you brought this to our attention. Tell us about this headline in the Journal Club Times, the most esteemed newspaper
Well,
covering Journal Club
yes,
activities.
the reason it's relevant, and there's a slide here, is this was the topic of our journal club 1 month ago. It was on the synthetics, what's out there, what's going on. We focused on HHC, um, as you can see, is one of the synthetics, and it's made a lot of splash, and not just in the United States, but internationally. We won't go over all the things we covered in the journal club. It's archived if you want to go back and look at that one. But it's a hot area, that's all.
Absolutely. And an ongoing one that's constantly evolving. I feel like I see advertisements for new things people are cooking up all the time. So, but we have a different question we're asking this month or issue we're raising. And Dr. Malloy, I thought it was a really great article you shared with the team that is raising up this issue. Is cannabis use common in the context of elective surgeries? Does it matter? And how might it impact anesthesia or surgery outcomes? And maybe you could set the stage for us a little bit by talking about the issue and what was known about it before we jump into the paper.
I think the standard of care is to know what your patients are taking in terms of medications and their problem list. Um, Physicians are and healthcare providers are encouraged to ask about alcohol. And I think we fall short of the expectation of legal and illegal other drugs that may not be prescription medications. And it turns out we have no skin in the game, by the way, the three of us or four of us um, that are putting on this journal club, except for education. And I think the patient's outcomes are better when our eyes are open as opposed to our eyes are closed. So the issue is, do you think that doctors screen for alcohol and cannabis use before elective surgeries as much as they should? And does it matter? That's the purpose of this journal club. You're muted, Jehan.
It has to happen once a week, I guess. Association, our featured article today is entitled Association Between History of Cannabis Use and Outcomes After Total Hip and Knee Arthroplasty, a systematic review and meta-analysis published in 2024 by Young and colleagues. And as you can see, we highlighted quite a bit in our PDF copy. So why do we care about this, Dr. Malloy, about TGA or this total joint arthroplasty?
Well, because the volume of these surgeries keeps going up every year. And here you see some estimated data from the American College of Orthopedic Surgeons that there are about 700,000 total knee replacements. In case you're not familiar with these abbreviations, TKA, total knee arthroplasty, and 450,000, almost half a million total hip replacements. And the numbers keep going up. And hard to deny that some of these elective surgeries are happening in patients who are using cannabis pre-op in addition to all the other medicines prescribed and otherwise that patients show up on. So it's not a rare thing. Whatever hospital you are affiliated with, there are a lot of joint replacements, elective, happening in your hospital.
All right, excellent. And also Len Kamen, Dr. Len Kamen has joined us. So Dr. Kamen, whenever you'd like, you can unmute yourself, throw on the camera, and chime in on any slide you'd like. But we're just getting started. Up next, well, I guess we have to think about how this study was done and who was studied. Well, this is a study that studies studies. It's a meta-analysis. It's sort of the top of the food chain or top of the pyramid in terms of research studies. And that is because it reviews all other studies to find commonalities. And so way at the bottom, we have the foundation like this cell-based research, animal research. We have editorials, opinion pieces, case reports, and series leading all up to systematic reviews and meta-analyses being sort of our most powerful ways of understanding outcomes.
I have a comment, Jehan, about this and the meta-analysis and that pyramid you showed. Some people criticize meta-analysis because they are often full of observational studies. If you reflect on the nature of some of the topics that we cover in journal clubs, like pregnancy and cannabis use, driving under the influence of cannabis use, pre-operative cannabis use, you can quickly come to the realization that although we all love randomized controlled studies that have good numbers and that control for all the other potentially confounding variables, there are some circumstances where RCTs are not ever going to be done because they're not appropriate. There will never be a study in elective surgeries randomizing some of the patients to cannabis and others not. There will never be a study on pregnancy that randomizes. So I would like to just upfront say, I know we're all spoiled and we want big RCTs, but meta-analysis of observational studies are all we're going to have for in some circumstances, and that relates to this one.
And just to show you a little bit of visualizing meta-analyses, because most of the figures we'll discuss have to do with the meta-analysis, you can see on this cartoon on the right that there's these different studies grouped showing an effect, either in an outcome, a positive outcome, or either a negative outcome, depending on which direction it's going. And then the overall effect is usually depicted as this triangle down here on the right side. And again, this is great because you can take 5, 10, 15 studies, combine them, and look at the commonalities to draw research conclusions. I know, Teresa, you've done a number of meta-analyses and research protocols and clinical studies.
Yeah, I
Anything?
think that this is a very good overview, but there's a lot more that goes into it, right? So it's, but yes, this is perfect. I mean, because then you weight them and you know the level of within each paper, right? So that and they do that in this paper. I'm sure you're going to get to that. So the rigor, you know, around the meta-analysis.
Absolutely. That was just sort of my instant noodles of what is a
Yeah, it's
meta-analysis.
great. And no, it's great. It's great. 'Cause we don't want to spend a lot of time on the methods like in that way. So it's perfect.
So, so this
This,
meta-analysis by Young and colleagues was actually a really big study. We're talking 5.9 million patients included with lots of endpoints analyzed. And Dr. Mulay, do you want to take us through some of these endpoints that they looked at, sort of the major
sure. I don't
buckets?
know how many people read the studies in detail before the journal club, but the authors said, let's look at three different types of outcomes. Prosthetic complications, and the specific ones are listed there. Systemic complications like cardiovascular infections, blood clots, and that. And post-op pain and morphine consumption, which is a very relevant one in this day and age in general, and the fact that we're looking at cannabis and surgery and people who are in pain and receiving other pain medicines. So one could postulate maybe the use of cannabis in the perioperative period or preoperative period is good for pain. And let's look at all these things. So prosthetic complications, loosening, infections, systemic complications, and pain and opioid consumption. All opioids were um, calculated as morphine equivalents. There are formulas. If you're on oxycodone or hydrocodone, you can turn them into morphine equivalents with conversion tables. So that was the outcome. Those are the three types of outcomes. And we'll look at some of these results in just a second.
So we're going to look at figures 2 through 6. There's a number of tables and figures in there, but we only have about to the top of the hour, so we're going to go kind of just dive right in. And real quick, if it's been a minute since your last biostatistics class, just want to remind you of what a forest plot is. There are two types. We're looking at risk, relative risk, and so the forest plot is set at 1 on the vertical axis, and you look at is it less than 1 or more than 1. If you're looking at averages, which I think there's one figure here, like what is the average blood pressure or something like that, that is usually set at 0. But again, typically we see this type of graph with a vertical line, and the effect of the study that they're looking at will be grouped there with a diamond, usually a black diamond, indicating the overall effect size. So let's move on to our first forest plot. This is figure 2 on prosthetic complications, and you can see that there are a number of subgroups within these studies. So you start in the left-hand column, you see it's entitled revision or mechanical loosening or periprosthetic fracture. It has the author name and year, and then sort of the events in the cannabis group, the events in the control group, and a risk ratio. And on the right here in blue, the little blue squares with the bars are the effect sizes of these individual studies that looked at this. And the black diamond is, in a sense, the overall effect they're seeing. In general, we're seeing a black diamond on the right-hand side of the 1. Dr. Malloy, does not seem
Yes.
to bode well.
First of all, the wider the diamonds are means it's the confidence interval is wide. The skinnier the diamond is a tight conclusion, means there's not a lot of drift, and the studies sort of were consistent with each other. And the fact that none of these diamonds, there are five major outcomes here under prosthetic complications. None of these diamonds crosses the vertical line, means that it's statistically significant in favor of, in this case, an adverse outcome. The relative risk is greater than one for all these things. The need for a revision, that means you have to redo the surgery. Mechanical loosening, periprosthetic fractures, dislocations, and infections. None of these conclusions cross one. They were all statistically significant negative associations with the use of cannabis. This is not randomized, this is observational. But the numbers, as you saw, are pretty big.
Can I add here? Can you hear me?
Yes, thank
Yes.
you, Dr. Kamen.
Most of these complications occur way down the line. They don't happen the day of surgery or within the 2 weeks after surgery when they're hospitalized. You might have more accurate data. So, there are lots of things that can happen, and doesn't give you the timeline for when revisions or these findings of prosthetic failure were really identified. And they could happen 3 years, they can happen 20 years, into this. So I find it kind of weak that there's no timeline here for these occurrences and how they could then construe this to be cannabis related. Not that I'm absolutely being defensive of the cannabis clan, but I just think it skews the data from this meta-analysis study. It doesn't give us enough specific information.
That's a great point. And the reason there's no time frames here is because each of these individual studies, there's dozens of observational studies here, has different time frames. And
Right.
Right,
and
and
they're
that was
not
going to be my
consistent.
point to both of
Yeah.
you. We don't know whether within each study they adjusted for time, and that would be something that is probably a limitation of the meta-analysis because I don't they may have done lots of subgroup analyses adjusting for that. That's an interesting point, Dr. Kamen. So,
And I want to rephrase what you just said, Len, and tell me if I'm right or wrong. The association is statistical, and it does not imply cause and effect. If I have an infected prosthetic joint a year or two later, it happened more. All I can tell you is it happened more in the cannabis users than the non-cannabis users, with no comment on whether or not this is cause and effect.
Absolutely. It detracts from the weight of the study at all.
Yes,
And it's
I'm
confusing.
not sure we'll ever get better data. That's one of the things I was trying to get at earlier.
Yeah.
Oh, so for figure 3, they continued their approach looking at systemic complications, and to add to some of the strength and weakness discussion we're having here, it's also not separated by administration form. I think, if we're talking about certain issues arising from a smoking habit, that might be different than consuming edibles or oral ingestion, or definitely, I think, topical as well. But here they have different studies or subgroups within studies, such as cardiac complications, cerebral vascular accidents, pneumonia, respiratory failure, UTIs, kidney injury, and ileus. And the news looks a little bit, it looks like there's some really tight groups here. And it also looks like there's a lot of variation in some groups here.
Once again,
But
did they separate I forget in the data, did they separate smokers, cigarette smokers, tobacco users, or alcohol use in this group from others?
That would probably be up to the individual studies. Some of them for sure tried to control for that, and other ones I am unsure. So we'd have to go and look at some of the individual studies. So I think that's a great question if we're looking at, say, the cardiac complications, and we wanted to say, okay, well, there's this study that has a lot of variation by Vaccaria in 2021. Maybe that huge degree of variation in their little blue box
Yeah.
has to do with the fact that, yeah, there is maybe some contaminant alcohol, tobacco use as well.
Some of these adverse outcomes make mechanistic sense. One of our earlier journal clubs was a review on cardiac associations with cannabis use.
Yeah,
So they make, if it's smoking, respiratory is well documented as well. So there's a mechanistic suspicion enough to at least raise the question. This is worth looking at, which is what the authors did here. And the only one that crosses zero, obviously, is ileus, the GI. You don't move your bowels after surgery, anesthesia type of thing. And there it's pretty obvious. There was only two studies that looked at it, and one was to the right, one was to the left. And when you put them together, no statistical signal here.
Interesting. Definitely, I'm curious to learn more about some of these in terms of their time frame, and the type of surgery they were going through. Um, but I think these are interesting trends that are able to be pulled out of this data. But if there's some grad student listening to this, you could dive deeper into some of the subpopulations of cannabis users or exposure that they're looking at in these studies.
Yeah, well, maybe we can get through this and then we have lots of comments, I'm
Yeah,
sure.
yeah.
So one of the hot topics, as always, when it comes to cannabis use, is opioids. And morphine consumption can sometimes go up and sometimes go down, depending on the group and who's looking at it. Um, However, it appears in Figure 5, which is a forest plot of the mean difference, so it sets at zero, between patients with a history and without a history of cannabis use. And again, this is after elective surgery. And so overall, the evidence level for this pooled result was low, which is interesting, but the variation looks quite interesting as well. So as you can see on the right, the little green boxes, the little green dots are the study, and their effect size, the mean difference, mean change, is represented by the line. And so you see some cross over zero, some had a big reduction, some had an increase in morphine use or opioid use.
You commented when we were talking about this earlier, Jehan, that the study that most dramatically shows less opioid use was the oldest study here, 7 years old now. I
Yeah.
wonder if there's anything.
So in
Yeah,
2018, people were using it looked like a lot of cannabis to reduce their reliance on painkillers. But as the years goes on, that effect size diminishes. And this was
right.
at a time, I think, shortly after a famous study by Bachhuber, which looked at opioid overdose deaths and cannabis use laws and found an association in states that had cannabis access programs, whether adult use or medical, seem to be having less opioid deaths, which was interesting and a remarkable public health finding. However, this trend seems to be changing, and I don't know if it's because habits of use or behavioral use patterns have changed, or just the way we're asking the questions have changed. No longer are we saying, hey, is there a medical cannabis law? We're actually saying, well, or how much are you using? What is the frequency? Is starting to drill down on that.
Those comments of yours are very relevant because this paper is looking at users versus non-users, and there's no accounting for dose of exposure. The binary, yes or no, you're exposed to cannabis pre-op or you're not, which is a criticism of this paper. If I had one dose in the past month, I am a user, the same as somebody who's using a ton of it every day. It is yes or no.
Well, Dr. Kamen, I know you're a bit of a pain expert. When you see this type of variability, what comes to mind?
First, that there are trends from 2018 to 2023. There are trends that the orthopedic groups that are prescribing these meds have really ramped down their volume of medication of opiates, and the anesthesiologists are doing more with longer acting, concoctions of anesthesia to prevent opiate increases after surgery. So it's again being skewed by a lot of different inputs here. I think morphine consumption, depending on accuracy of its use and over time, is trending downward altogether, regardless of whether they're cannabis users or not. We haven't seen a direct absolute response in regards to the analgesic property of cannabinoids in this study or any to a great robust degree.
Interesting. That's interesting factors that are influencing this. One is increased availability of cannabis products and ease of adults to get them and some medical acceptance around their use. Then there's also the fact that just less opioids are being prescribed, different formulations are being used, and so we have this intersection, and we might be seeing it playing out here on a forest plot. So there are a lot of factors to think about with that. That is great. I love it when we can start to think about how society has been influencing scientific results. So we have one other figure before we move into the summary, and that's on transfusion requirements. And so this is looking at relative risk. So the forest plot is set at 1, looking at postoperative transfusions between patients with a history of cannabis use. And again, we're seeing this 2 studies in blue, these little boxes, their effect size, and then the black diamond indicating, just again, based on these 2 studies, that it seems to be an increased risk of transfusion requirements. And again, I'm not entirely sure what this might mean for someone going into surgery. I don't think it necessarily means cannabis is bad for the blood, but it could indicate other things.
Not sure.
Again, a very interesting issue.
Yeah.
All right. And so just to summarize this article, there's 3 parts. So the perioperative cannabis use in the study is associated with more complications. There's periprosthetics loosening and fracturing. There's cardiovascular and cerebrovascular events. There's pneumonia, respiratory issues, UTI, post-op transfusion, acute kidney injuries, and VTE, which I can't remember what that is at the moment.
Venous thromboembolic disease, blood clot.
Thank you. So a lot of associations there. However, perioperative cannabis use is not associated with ileus or pulmonary embolism or changes in opioid use, which again, I think are good news. There definitely are trends downward for opioid exposure and opioid use. Is it entirely associated with cannabis or responsible for the effect of cannabis? That remains to be determined. So I think one of the challenges of this article is, are these associations believable? I think we already stepped a little bit on that rake, saying some of this stuff makes sense, some of it doesn't make sense. And how relevant are these findings? I mean, based on the methods or what we know about the methods of the study. And again, generally, I think this article points to 2 recommendations. enhance clinician and public education on associated risks with these products. Because if you are in a vulnerable population for cardiac issues, it might be something to consider with your cannabis use before going into surgery, as well as having improved screening and questionnaires and documentation would help a lot. Moving on, the study basically concludes it is possible that cannabis impacts the post-op course of total joint replacement and other surgeries. Again, there could also be drug-drug interactions that are happening with anesthesia. Very little is known about this. And many patients en route to elective surgeries are cannabis users, and their anesthesiologists and surgeons may be unaware of this.
Yeah, so I'd like to make a point about that because I think two things, right? I don't think that there's a systematic way of collecting this type of exposure prior to surgery. I mean, we know that, right? It's because it's not federally legal, that's, most patients' charts, whether they use it or not, may or may not have it in there. And it's also, very few people will say that they use it if it's not like they don't have a medical card. But I think that for me, I guess I would really, what's missing is how was the actual exposure, the cannabis exposure collected and documented in each of those studies. So you do a systematic literature review, there's lots of tables that you create and you try to convince the reader why you chose the papers that you chose and why they seem to all be like, okay, this is a systematic literature review and we want to answer this question. And the tighter that you can get those populations that are similar, the better off the overall point estimates are. And even though there's confidence intervals and all that other stuff, we don't really get a sense of what's in those papers. And the ones that were not included, right? They give you this high level, but a lot of papers give you supplemental information around the papers that were not included and a little bit more rationale around that. I did look at their supplemental tables and it only has about the ratings of the included papers. So I don't, I don't know if I buy it. I guess that's really, I don't know if I buy this. I think that there's more research. My other last criticism of it is that they say that they did this literature search in August 2023, but there's no, like, they don't say when they looked at the papers. It's just August 2023. They just picked what was out there. But usually when we do a systematic literature review, we do for the past 10 years, and I didn't see that in the paper. I may have missed it, but so those are sort of my criticisms of it. And I don't know if I believe the results, but I might be one of the only people that
I'd like to hear both from the audience. Who believes these conclusions? Who believes that this is a real association and who doesn't? Yeah, that would be an interesting poll question too.
All right, well, you know what? I think we can ask that poll question here. I'm gonna launch that right now. So if you do using from a friendly device, you can start to answer the study. The question is, the study provided evidence of an association between pre-op cannabis use and post-op adverse of outcomes. And that's, again, it's just a personal choice, personal belief. We shared the data. We talked about our biases. And again, the results are coming in hot. 90% of participants. Fantastic. Thank you, everyone. All right, and I'll close the polls. You have another second to change your mind and get the answer right. Just kidding. All right, closing the poll in 3, 2, 1. All right, and sharing results. You should be able to see this live. Sometimes it doesn't show up in the recording, but 27% of you said yes, the study provided sufficient evidence of an association between cannabis use and post-op adverse outcomes. And 73% of you said no, that perhaps the methods were a little too loosey-goosey, I'm guessing, or some of the associations you thought were just associations and not causative or something like that. So fascinating finding here. Appreciate your participation.
Yep.
We have a comment in the
Interesting.
chat that says sufficient is a strong word. So maybe next time we have to choose
Well,
our words wisely.
Maybe
and bold.
adequate.
Yeah.
adequate.
You know,
So Teresa,
if this
I-
was a study of, the effects of low hemoglobin on post-op complications, they would take a hemoglobin level
That's right.
before and after these procedures, and they'd say, "Oh goodness, we're seeing more thromboembolic events in those people," and yada yada. But since it's such a vague association of, again, inaccurate data collection for what cannabis was being used, how often it was used, if it was in their system when they were undergoing the surgery, and the time frame for any of these complications had something or nothing to do. That's the data that's missing, that makes this a less than valuable study, despite its gazillion N number.
No, exactly. It might almost be worth, dare I say, repeating.
yeah,
So to Jahan's
If it-
point, if there's any postdocs, I mean, now I really, it's probably one of the things that I most enjoy is doing systematic literature reviews. I mean, they are very time consuming. However, this one, it might be worth really like repeating it to see, um, what actually comes out and like with an update. But the problem is that the data, the exposure data is not systematically collected. That's the biggest limitation, is we don't really know. And it would be nice to really get a sense of whether it was patient reported. How did they figure out who was using cannabis and who wasn't? So that's what's unclear to me.
this reminds me, I'm honored those comments. Thank you. It reminds me of, in contrast, the series of pregnancy articles we did 6 months ago, whenever it was, where virtually 100% of pregnant women have a urine that's saved. So they could do a drug test on the urine test that was closest to delivery, and then you get data. You don't have to rely on what you wrote in the chart. Somebody self-reported something that was not accurate. So if we only had a urine test as part of the pre-op workout here, that
Yeah.
would increase our confidence that we are putting people in the right buckets: users, non-users.
Right. I mean, and that would be used for anything, right? I mean, I think that
Right.
pre-op to understand the person that's going in for,
Right.
Well,
Yes.
it would address the immediate complications perioperative, but it wouldn't address those long-term complications,
No.
no, you're
peripatetic
100% correct.
loosening
Right.
and failure due to all these other complications, because they
Right.
come way down the line.
All
Yeah.
right. I think we've
Have any more?
addressed this as people are scratching their heads for some incoming questions. Feel free to post them into the chat, raise your hand, or if you don't know how to raise your hand, you can just unmute yourself. But we just have a few more little tidbits to round out the discussion. And we sort of
And one
talked
more
about,
poll.
oh yeah. Oh
One more
yes.
poll question.
Yeah, you're right. How did you know? So we will throw one more poll question out to the group. Um, and let's just see. Let's launch this. Oh, is that being poll is oh stop sharing. And let's go back to launch this one. All right, so if you were an orthopedic surgeon or anesthesiologist conducting elective surgeries, would you universally implement a drug screen as part of your pre-op evaluation? Yes, no, I am not sure. Only patients I deem to be a higher risk. There's also a question here. Healthcare providers are generally informed about an association between pre-op cannabis use and post-op adverse of outcomes. Feel free to put your answer in the chat. Appreciate your responses. It's always fun to see what people do in response to data. Very interesting results coming
Yeah,
in.
yeah. So I'm going to criticize your question, Jahan. So especially the first one, because I think that the yes would be if the, I guess this is what I would like to add, if the patient agrees, right? I think that that's the biggest piece here. So are we assuming that the patient agrees?
Yes, we're assuming this is conducted in a legal hospital following all applicable
Okay.
regulations and
All
patient
right,
state
perfect.
guidelines.
Just wanted to like, make sure that that was,
Yes. This is not a criminal investigation.
no,
Uh,
but it's about
yes,
consenting, right? Consenting to the
right,
test.
absolutely. Um,
And to Phil's
allowing
point, when we talked about it earlier, those that don't consent, maybe you should think about it, right? Like what's
or
happening.
who is paying for the drug test? I think
That too.
that's the
Yeah.
most important question we've had tonight. If you're going to do these extra things, who's who's going to pay for it? That is a great comment from Gaetano. Thank you.
It's
But,
cheaper than a CBC.
we, so we see some really interesting results split between yes, we would let the patient opt in to do a drug screen as part of an evaluation to take that into account. And about a third of the people, 36%, said, I am not sure, um, which I think is in line because the next question is healthcare providers are generally informed about an association with pre-op cannabis use and outcomes. 10%, 9% said yes, and 90% said no. An area for further education and discussion there. Um, Excellent. Well, very interesting results. Thank you for your participation. We did have a few more slides, but if anyone has any questions they'd like to ask the group, we tried to study the paper to the best of our ability. So if you have comments or questions, you're welcome to raise them. But I will just move on until anyone else has questions. So from the paper, again, this doesn't represent necessarily anyone's views here, but from the paper, they did offer some possible explanations, and what better way to communicate those than in their own words. So when they talked about mechanical outcomes, so um, having to redo the surgery or loosening or fractures or joint dislocation, they said that plant compounds may decrease proprioception and may impair motor coordination, which could contribute to these risks of revision and fractures and joint dislocation. But I feel like you could say that about so many different medications that affect pain sensation, and what type of lifestyle they're leading, because maybe they get that hip and then they go right back out to playing in their baseball league again, and something like that. And they feel better because they're using cannabis and Tylenol and taking hot baths or whatever they're doing. And so they push themselves a little too hard. But again, the authors are trying to think about what could possibly explain this.
Well, number one, do we agree? Are there data definitely showing a decrease in proprioception because smoking a joint may give somebody greater musical, talent skills, or at least they think so. And has that data been, definitely shown at this level of impact that would cause prosthetic failure?
Uh, I sincerely doubt that. I think this is sort of their supposition they are making. The other one, which was interesting to me, and I don't really like this one, but so I thought it would be fun to disentangle a little bit, but they talked about infectious outcomes and the observed higher risk of infection with cannabis use in our meta-analysis may reflect the ability of phytocannabinoids, other compounds in cannabis smoke to suppress immune response. And I see this a lot with cannabis. People say, "Oh, it inhibits the immune system. It must be bad." But it's like, well, inflammation is part of the immune system. And I don't know enough about hip and knee surgeries, but I imagine too much inflammation is not a good thing. But you probably want some inflammation. So could you have too much of an anti-inflammatory effect, and then the healing compounds from the natural inflammatory process don't get there, right? that it's not concentrating those factors, those humoral factors that might be important. But I'll leave it to the MDs to correct my PhD philosophy there.
I can't make any heads or tails of that.
Yeah, it is. I think they're conflating a little bit of the anti-inflammatory effect, the effect of cannabis of suppressing the immune system, um, and trying to associate that with a higher risk of infection. Maybe if you're smoking really old, dirty flower, uh, then that could lead to. But I don't understand how that would necessarily affect the surgical outcome.
Well, in general, are aware that the cannabidiol, the CBD, is a response. It's a pop-up response to inflammation. You need that in terms of to indicate to the rest of the immune system the need for healing. So I think it's a weak point.
We- It's weak sauce. Got it. All right. And then one of the things the authors end their paper with is what cannabis paper could not end with talking about use disorders and the association of an increase in cannabis use disorders or increase in tracking it. Given its association with postoperative issues, it is crucial to screen for cannabis use to allow for timely counseling and perioperative risk mitigation. So I think as a blanket statement, as this information develops, maybe there are extra factors to consider when someone is using cannabis to treat their pain or maybe recreationally when going into surgery. And again, I guess I would say any factors that you can reduce uh, that might complicate something, perhaps the better. Um, um,
I don't think they've been conclusive that this information is that critical, given that there's so many questions about its value immediately, perioperative, and long term.
that's a good point. Well, the good news is this is a very active area of research. People are looking at cannabis use in anesthesia, outcomes. Um, since just the publishing of this paper, there have been other papers that have come out that could be added to a new meta-analysis. And the main area I think we are concerned about or have questions about is the drug-drug interactions between cannabis and various medications, including those used in anesthesia. And there are many papers showing that cannabinoids, whether it's THC, CBD, or some yet to be named cannabinoid that people are using in large amounts, can potentiate the effects of these opioids. In some studies, for example, with morphine, you see a reduction in use because people are reaching that pain threshold pain reduction threshold that they want with cannabis and morphine combined. However, we doesn't mean that it holds true for every anesthetic that is used out there. So there's some interesting questions to be asked. It'd be wonderful if THC could reduce the reliance on some of these anesthetic drugs, but that remains to be seen. But there is a really great review about some of the more molecular mechanistic things, receptors and proteins and signaling factors, entitled Cannabinoids in General Anesthetics, Revisiting Molecular Mechanisms and Their Pharmacological Interactions. So plenty to dive into there.
So yeah, to everyone, I guess, I always also have a look at going back to the paper, the funding, right? Like who funded this work. And was supported by the Traditional Chinese Medicine Evidence-Based Capacity Building Project of the State Administration of Traditional Chinese Medicine. So it's if that's a little interesting to me to see that, it was funded by one of those groups. It's almost like they were looking to, and Phil and Len, you know this, like where, um, like to make an argument about something that would be then practiced within the country, right?
Yeah, thank you. I missed that.
Yeah, so it's I always think about things, so there was, I think all the authors are from China. And so sometimes these are done to change practice. As we know in the United States, there's a lot of societies that get together to actually change the way we diagnose something like, the blood pressure, is 120/80, but yet it could be something else for different subpopulations like diabetic patients and metabolic syndrome and the like. And when do you transfuse a person with hip and knee surgery? All of those things. And so I was just curious, it's just a comment. No one knows the answer, but I wonder if this will be used to change practice in China.
Well, they grow more hemp than anyone in the world, and in 2018 they started growing their first government like CBD oil uh, flowering plants for medical or drug use, whatever you want to call it. But China has huge, huge hemp fields in Harbin. They're grown not too far away from where McDonald potatoes are grown for French fries. So if you
Oh,
can, if you
maybe
have
that's
the
why they
means,
taste so good. They get the runoff water from the hemp farm.
there you go.
When I was a kid, though, I remember we used to have a saying that good rope makes bad dope.
I don't think the hemp industry would appreciate those comments, but that's
I like that. I'm gonna have to remember that. That's great.
Yeah.
well.
All right. Any other comments from anyone? We're approaching the hour. I mean, we have a
So I
lot
just
of great
wanted,
comments in the chat. I've been monitoring it. And one, Gaetiano asks about the AI tools used in meta-analysis. And that's, they are starting to do so like that linguistic pieces. It's not foolproof yet, but there are some projects that do look at that. And so I mean, it would be interesting to just, do a quick lit search to see what is being published using those methods. So thanks for the reminder to stay up to date on that.
This journal club has motivated me to want to keep up with the literature on this, to see what is coming out. Every 6 months, I'm going to search it again and see what's out there.
Mm.
speaking of staying up on it, our next journal club, first Tuesday of every month, will be on April 1st. That is not a joke. It will really happen on April 1st. It's the first Tuesday of the month at noon. And we're going to be discussing some research on cannabis and dental health outcomes. So some interesting stuff there. So we
Yeah, are
want
there new products like floss with this or something? Like, wasn't I like hearing or reading about this? Like, it's just incredible.
no, not yet, but that is something I have proposed to other people in the past. Yeah, I don't know
All
if they've
right,
made it yet, but yes.
Okay.
great.
Although I don't know how I feel about weed flavored dental floss. I think that might cause more questions than answers.
All right.
All
All
right.
right,
Thank
You
you,
gotta run,
everyone.
guys.
Bye.
Thank you, guys.
Yeah,
Thank
thank you
okay.
you.
so much. All
Thank you,
right.
everyone, for attending. We appreciate you. Thank you.
Don't end the meeting, Jay Hunt.
All right.